Hey everyone, welcome to the Mettle podcast. My name is Eric Norman and I'm a physical therapist. And shortly, we're going to jump into a topic with colleague Christian Jorns, who's also a physical therapist, on neuropathic pain. We're going to talk about an article that discusses the 3 different types of pain. And it's a pretty interesting one. It's not one that we've, like a normal one, I guess, that we've done before. This one's a little bit more, I think, abstract, can be a little bit harder to really digest in one listen. And so encourage re-listening to this one a couple of times if you need to. But at the end, Christian and I go into, I think, some really good, cool ideas on how to treat something like neuropathic pain and some different ways around that. So anyways, thanks so much for listening. Have a great rest of your day. Bye.
Right away, I just want to get into quick, set the stage of what neuropathic pain is. So, as it says in the article, right away, neuropathic pain is caused by disease or injury of the nervous system and includes various chronic conditions that together add up to about 8% of the population. So right there, neuropathic, we're dealing with pathologies of neurons, pain caused by disease to the nervous system. We also have 2 other forms of pain. Nociplastic. Nociplastic pain, that's when we think of things like fibromyalgia, maybe like some CRPS going on. That's more of the central nervous system changes. And those things can be seen a lot more in chronic pain individuals. Lastly, we have what's called nociceptive pain. And nociceptive pain is the most common type of pain. That's when if you break a bone or, sprain your ankle, that's going to be that nociceptive pain that you feel. That is that acute pain that's being sensed by those peripheral nerves traveling up the spinal cord, brainstem, into the brain, telling us, hey, we have pain and we might want to try and do something different because we feel like we're in danger.
Yeah, I think that's a great introduction to it. And I think I'm going to just piggyback off where you just ended and just defining what is pain. There's lots of fancy definitions, and there's probably a couple in here too, but the one I like to think about is pain is just your body's way of warning you about real or potential danger. And it's not a perfect system. And often your pain level does not match the real amount of damage you have. And an example of this is a paper cut. You have a very small amount of tissue damage, yet they can hurt a lot. Or you'll hear about this a lot in the opposite. You'll hear about car accidents or people that are in war where they might have broken bones or they have wounds from shrapnel, whatever, and they have no idea for many, many hours until the event is over and they get a chance to process because their body is more focused on survival and it's really distracted. And that wound does not matter right now. Other things are far more important. And this is also important in that you can have pain without having any tissue damage at all. And so something else to keep in mind around pain is that most tissues, your muscles, your ligaments, bones, tendons, they all heal in about 3 to 4 months, give or take, physiologically. And if you have pain beyond that time, yeah, you could have a slow healing thing like a really, really bad fracture or surgery. You could have a really slow tendon repair or something. But it's also very likely that your body is still being overprotective of that area and giving you pain when it shouldn't. And that's going into those different kinds of things like Eric was talking about, like nociplastic pain is an example of that. I also think, just to finish setting the stage here, when it comes to thinking about pain, we should think about what structures in your body are really involved in all this. And there are 3 major ones. You have detectors, you have your brain, and then you also have the nerve itself. So your detectors, these are things that are located in your skin, your muscles, your ligaments, pretty much everywhere. And they detect different types of things like pressure, temperature, vibration, movement, position, all these different things. And there are even specialized ones called nociceptors that detect potentially dangerous amounts of these different things. And they're often also called danger detectors for that reason. And then when these detectors sense whatever it is, they send a signal through your nerves to your brain. And now the brain, that's a thing that's receiving all this information from these different detectors. And it combines things like the amount of that stimulus it's getting, how rapidly it's getting it, your past experiences, your expectations, your beliefs, and a bunch of other stuff that your brain thinks about. And it puts all that together to give you an output of, let's say, no pain or pain. And if there is pain, to what degree, where, all these kinds of things. Then the last little bit of this is the nerve. This is, I guess, the simplest one here, where it's just the connector. It's the wire. It's the pipeline that connects your detectors and your brain so that everything can exchange information very fluidly.
They have a really nice diagram here. So if you're watching the YouTube video on it, I'll pull it up to the camera. So Christian very well explained how that diagram works succinctly and to a T. So good job,
it's the only
Christian,
way I can make sense of it.
A lot of abbreviations on that page. So yeah, so like Christian's talking about, there's different components to how we detect pain. I would say in a healthy manner, right? If you break a bone, we want to know that you broke the bone, right? If your hand is on a hot stove and your hand gets burnt, we want to know that there's a hot stove there because that's going to protect you from a lot more damage from burning yourself, right? So what can happen when we have something like neuropathic pain? What can kind of go out of whack, right? So the article lays out some different things that can happen when we're experiencing things like this neuropathic pain. One of the things they talk about is ectopic activity. And so what that basically means is like an abnormal sensory change by the nerves. So maybe something like what Christian was talking about, a paper cut, to some of us might sting a little bit, might hurt for maybe a minute or so, but eventually we're going to realize it's not that dangerous and it's going to go away. For someone who might have this ectopic activity and abnormal sensation by the nerves, that paper cut might turn into like you felt like you got your finger cut off, right? So it's this abnormal change in how the nerves are sensing that quote unquote damage. Kind of goes along with this other idea of peripheral sensitization or hyperexcitability. So the excitability of the nerves gets higher, and what that does is that another stimulus that might come in contact with that nerve is going to be propagated more through that conductor or that nerve up to the brain. All right. Next, they also highlight something called central sensitization. Same thing as like peripheral, but this is just up in the central nervous system, usually up in the brain, where we can see things being interpreted a different way. So that interpretation can be more sensitive. Lastly, they actually go into two other ones, but I'm just going to really focus on one of them, which is called impaired inhibitory modulation. Now, impaired, that means something isn't working quite as right as what we would want it to work as. Inhibitory, right? So it's stopping, it's putting up the stop sign to something like pain sensation. Modulation. So that means that we're lacking the ability to minimize sensation of pain. Our brain does this all the time, whether we know it or not, right? If you, it's the old adage of like your leg hurts, so I punch you in the arm, and now your leg doesn't hurt anymore. It's because your arm kind of took over that, right? Your brain has a hard time focusing on two things at once. So if the arm now starts to hurt, your brain says, whoop, we have a more acute pain in the arm we need to pay attention to. It's going to inhibit or modulate the pain coming from the leg. And in individuals with neuropathic pain, that inhibition to that pain can be impaired or a little bit out of whack.
The two that I didn't really think much about, I know I've read about them in the past, but I don't think about them daily, are going to be ectopic activity. And then the one that you didn't mention was activation of microglia. Just to speak about ectopic activity for another moment, this is a really good one to be aware of for people that just get pain randomly. So normally the way nerves function is you have the body of your nerve sends a signal through the axon of the nerve, which is like the long little strip of it, and then it ends in the what's called the dendrite. Usually signals go from the body through the axon to the dendrite. But sometimes when you get stuff like ectopic activity, the nerves start making signals wherever they want. They'll make it from the middle or the end. They'll go up and back the other way. It doesn't really matter. And so what happens is, because you aren't getting these predictive signals in the typical order, you're getting pain intermittently, randomly. I think they use the word paroxysmal, just like all sorts of weird stuff is happening. And that can be helpful for us to explain to patients. They might be like, why am I getting pain in these weird situations? I'm not moving when it's happening. It's just kind of bizarre. It's like, yeah, that could be ectopic activity going on here. And there's not a whole lot I can do for that in the moment, but just make sure you're aware of it so you don't feel like you're losing your mind. And then the activation of microglia, that's a pretty cool one. Something I read a lot about some years ago, where we often think about pain being a product of just the nerves and how all the different connections in your brain process information, but it's also largely dependent upon your nerve support cells, which are your microglia. And if you think about the nerves being the race car, the microglia are the pit crew. They're the thing that makes the whole thing run really well. If the pit crew is not doing its job, you're not going to have a good race car. So you have to make sure that those microglia are doing their job really well of getting nutrients to the nerves, repairing the nerves, all these different things. And there's not really a whole lot I can think about doing in PT to affect that, but it's a fun little thing to nerd out about.
Unfortunately, there's no modalities or treatment technique to modify how microglia.
Maybe it's cranial sacral therapy, but we're going to bring that back. I'm going to move your cerebrospinal fluid with my hands somehow, and you're going to get better.
You're going to get us canceled by the cranial sacral people.
All three of them left in the world.
Yeah, it's a really good summary of how the whole activation of microglia, and how, if you think about a system that's very complex, has a lot of moving parts, and if not all the moving parts are moving well in sync, like the activation of microglia, things can kind of go awry. Anyway, moving on from the more nerdy scientific stuff and getting more into the evaluation assessment of neuropathic pain. They talk about some different things here, and things that kind of come to my mind, at least as a physical therapist, when we're talking about neuropathic pain and examination of it, is just some of the more simple things that we've learned in PT school. How to test things like, pain pressure threshold, or, testing things such as, hot and cold sensation, light touch versus deep touch, right? Soft versus, more noxious or painful stimulus. Those types of things, to see if there's anything that jumps out at us to show, oh, this doesn't look quite right. Maybe this is part of what's going on. And even in the article, they discuss, I think it's really neat, they discuss there's no one single sign or symptom of neuropathic pain. The best way I felt like that they summed it up was that each individual can present differently with neuropathic pain. And so we should do our examination techniques to figure out what jumps out at us, because that's going to make that individual therapy specific to what they're having trouble with, right? So we can kind of get a better idea of putting individuals into these different camps of the neuropathic pain based on what they're presenting with. As the article said, just to reiterate, there's no one single sign or symptom of neuropathic.
Yeah, and I think in order for us to get more into the assessment of like how we go about it, or how your doctor might do it, I think it's good just to give you an example of neuropathic pain. So like Eric said a lot earlier, neuropathic pain by definition is when the nerves have been damaged. There's something happening to the nerves, whether it's physical or chemical or whatever. And a not so dangerous example of this is when you fall asleep on your arm and you wake up in the middle of the night and your arm will not work. What has happened there is the nerve has been cut off for long enough to where it just momentarily is not going to function, and the signals from your brain to your muscles to tell your muscles to move your arm just aren't going to get there. And you need some time for that nerve to come alive again. Another example of this that's really common is going to be with sciatica. So when people have an injured disc in their low back, the compression from the disc material itself, or the inflammation that's around where the disc has been damaged, is just touching the nerve. That stuff causes the nerve to be unhappy, and it gives you signals down your leg. And going off of those symptoms that Eric was talking about, While yes, it's a very individualized experience, the authors of this paper did highlight how there's 4 major things that really stand out as characteristics of neuropathic pain. And they are numbness, tingling, burning, or shooting pain. Now, by numbness, it can be fully numb, but it also can be kind of dulled, like it's partially numb. Tingling, people often say pins and needles or prickling. For burning, I mean, it's burning, it feels hot. Shooting, I'll also hear electrical shocks. Some people will come into the clinic and say, I feel like I'm getting electrocuted. It's like, okay, all right, that's probably shooting pain. It's probably neuropathic. And then how do we assess this? Like Eric said, there's skin sensation testing. So we can look at things like your light touch or your sharp dull or hot cold differentiation. We also use reflexes. So we'll use a reflex hammer and we'll check various tendons in your body like bicep, tricep, brachioradialis, patellar tendon, Achilles. And each of those reflexes happen because of certain nerves. And you can check the integrity of the reflex. And if something's wrong with it, like in your bicep reflex, if it's not working right, it's going to tell you that you probably have an issue in your C5 or C6 nerve. And we can figure out what's going on there. It's probably a neck thing. We also look at strength testing of your muscles. So each muscle gets a nerve supply from different combinations of nerves. And then based on what muscles are weak or are just behaving differently, we can figure out which nerves are probably having trouble. I think it also makes sense for me just to talk about the 2 different types of nerves that we have. So we have spinal nerves and peripheral nerves. Spinal nerves are the nerves that individually leave your spinal cord between each of the vertebrae, each of your spine bones. And then damage to any spinal nerves will show issues in characteristic patterns along what are called dermatomes or myotomes. You can Google those images. They're pretty cool to look at. And then peripheral nerves, these are just clusters of spinal nerves. So when the spinal nerves have left your spine and they begin to group together in clusters, that's your peripheral nerves. And then when they get damaged, they'll give you a different distribution of symptoms, but it's still pretty characteristic. And we have maps describing those as well to ease our learning. And they're pretty cool to look at as well. And so based on your testing of skin sensation, reflexes, muscle testing, all these things, a decent clinician can figure out what's probably going on.
I want to mention too on this examination part of the neuropathic pain is they also go into some other testing that we don't do as physical therapists, right? That they can do as medical doctors, DOs, etc. Those things I can't speak on as heavily. I don't know if you have some more insight on them, Christian, but things such as like electrophysiological testing, laser evoked potential testing, different things of that nature that they can get real specific on different nerves in the body and test them and show, oh, this nerve, maybe it's the branch coming off of the sciatic nerve, like your deep fibular nerve or something like that, right? They can test that specific nerve and say, oh, it's this one nerve specifically that is causing this, that they can show. It's kind of like the MRI testing, but for nerves. So an MRI can give you a more clear picture of what's going on in something like the shoulder, more so than what we could, do with provocative testing. Same thing here, right? We can test the different nerves like Christian alluded to with, dermatomal, myotomal testing or different specific sensory testing of the skin. And say, I think it's probably this or this. But these different medical tests, they can get in there and be more, I guess, pinpoint with what it is.
A lot of the times we'll figure out that something's going on and we'll be like, hey, perhaps we should go to the doctor, like the neurologist, and have them do more of this advanced testing to check for that thing, but also other things that could be going on. And then a common example of this is if we need to confirm whether someone has carpal tunnel syndrome. We might be able to figure that out based on the carpal tunnel compresses your median nerve, and then you get characteristic symptoms along the median nerve distribution, which is usually numbness, tingling, burning in your thumb, index finger, or middle finger. And yeah, we can figure that out roughly in the clinic, but there could be other things causing those symptoms. And that's where you might go to your neurologist. They'll do what's called a nerve conduction velocity test. They'll poke you with a bunch of needles, hook you up to some machine, and they'll figure out what's happening with your nerves using that test. And that's a much more accurate test for us to confirm whether it truly is carpal tunnel syndrome or something else happening in your neck or whatever else. And so it's just like it's a continuum of treatments. We may not need to use that test for other things, but sometimes we need these tests to find more difficult diagnoses or find the best treatment for you.
We've talked about what it is. We've talked about the examination and assessment of these different neuropathic pain symptoms, how to look at it. I think it's good to go next into some treatment. Starting off with treatment, let's start more, I'm going to say medical, and then we can get more specific with physical therapy. So, Christian, what were some of the different medical things that were presented in this article? I know they talked on things like medication, etc. What was your overall take on those different medical treatments for things like neuropathic pain?
My main takeaway was obviously meds are out of our wheelhouse. We are not licensed to prescribe medications. But I will say from the article and from what we know that medications are often first-line treatments for neuropathic pain. The one thing I do want to lead with is a quote from the article where they said, education about the natural history of the patient's underlying neuropathic condition as well as the limitations of currently available pain treatments helps generate appropriate treatment expectations. That is, current therapies are often not curative and residual pain, even during treatment, is common. Basically saying, yeah, we still kind of suck at this and we're sorry, like nothing's perfect, but we're going to try to use a combination of things like medications and injections and PT or whatever else to help you the best we can. So like I said, medications is definitely first line. We try to use those when appropriate. And there are 3 major types of medications that are described in this article. They are antidepressants, anticonvulsants, and opioids. And this article goes into a lot of detail around how many people do you need to treat for one person to get benefit. And the numbers are all pretty decent. They're like around, 4 or 5? That's pretty good. So we know that they're fairly effective, but one doesn't really stand out from the others. It's not like opioids are crazy, crazy good compared to the other ones, which is partly why we've gotten away from those, not to mention all the other negative things about them. So all these different drugs work to varying degrees. And then depending on your flavor of neuropathic pain, you and your doctor might decide which one to go with. And then an example of this is we know depression is strongly linked to chronic pain and can amplify the pain that you're having. And so perhaps working on your depression is likely to be of benefit to your painful experience. And maybe an antidepressant could be something you and your doctor talk about. So not only would it be helping the depression, it could be helping your pain as well.
Another thing that I thought that was really interesting, and we'll dive into this a little bit more later on, but going off your point that you made, Christian, on things like depression and using antidepressants, they also discuss oftentimes with this type of pain is a multimodal, so different treatment styles, but also multidisciplinary. So different healthcare professionals, working together to help a patient. And one of the things they talk about as well is referring to someone like psychiatry to work on things, especially tied to things like depression or anxiety or fear-related issues around the pain, which, I think personally, a lot of people with pain would really benefit from, a psychiatric referral, just because based on how much we know the emotional stress that can be put on someone with this type of pain or pain in general. And then another one as well that I wanted to bring up that I personally have had a couple of patients now actually with a chronic low back pain. They've come in and they have what's called spinal cord stimulators. And so it's this idea of trying to, artificially stimulate a path in the spinal cord that we know brings that information up to the brainstem and then into the brain, and trying to help artificially with the stimulator to help reduce that sensation of pain. That's what I tried to say. So anyways, a couple other things as well from that aspect that I thought was interesting that they touched on in the article.
Yeah, I can't say I've had anyone with a spinal cord stimulator in this area.
Oh, really?
I don't know if we're just not getting them at our clinic or it's not done much here, but I would love to see that in person.
Side note, I've also had a patient who has Parkinson's, and he has a deep brain stimulator on like the temporal side of his head. And when it is on, you couldn't even tell that he really had Parkinson's. And then he actually offered to turn it off just to see what it looks like. And so he turned the stimulator off, and within probably 10 seconds, not even, he started getting resting tremors, and his balance, coordination, everything was way worse. And then turned it back on, and it's really interesting. Every time he turned the stimulator back on, he always coughs. So he turned it back on, and he just went, and he was back to normal. And I'm like, oh, well, science is really cool.
That's pretty sweet.
But
I have not seen that either.
Yeah, it was. I was kind of scared. I'm like, don't do it. He's like, no, it's okay. I can turn it off. Don't worry. I'm like, I don't want anything to happen.
He wanted to show you. He thinks it's cool too. Yeah,
absolute
right.
Show off. Yeah.
Well, the next thing that I think is important to talk about going off of multimodal is, let's say you've been doing PT, you've been doing chiro, acupuncture, massage, just time alone, hoping it gets better. You've been taking different meds. You tried antidepressants, you tried anticonvulsants, you've maybe dabbled in opioids. You've done all these different things. There's also interventional pain. So interventional pain is, I wish they had a different name, but they're anesthesiologists or surgeons that do specific techniques to modulate your pain. And then various techniques would include things like neural blockades, spinal cord stimulation, intrathecal medications, rhizotomies. Rhizotomies are just where they go and they cut the nerves. Mm-hmm. It's not a permanent solution, but it can certainly help in the short term. They'll even do imaging guided injections. So if you have a lot of low back pain that might be coming from one of the joints in your low back, they'll often go in and do imaging guided injections directly into the joint itself, called your facet joint, and that can help your low back pain. And so these interventional pain doctors, which I'm grateful that we have one at the clinic I work at now, he's been a big help for some of these more complicated patients. They can offer you a lot of different things too, to be done in conjunction with all the other things that you're doing. And even, I think the article goes on to say that we should also consider doing these interventional pain things when people are not really getting better or having enough benefit from a medication or two. Maybe you made one or two changes. Don't just keep giving them the runaround and try 5 or 6 different medications over many months to years. Just go on to interventional pain, do the thing. It's pretty safe and it's worth doing. But I will say, they had a quote here regarding interventional pain. They said, no more than 40 to 60% of patients obtain lasting, even though partial, pain relief. So that means that it's basically a 50-50 shot whether you're going to get some help with your pain by going through one of these operations. And so I don't want people to go into interventional pain thinking, oh, I finally made it to the anesthesiologist, the bigwig who's going to help me. It's like, maybe, I sure hope it works, but chances are it is going to help you a little bit. But even then, your chances aren't great. So please keep doing all the other things that you are trying to work through, like your medications, your counseling, psychologist, PT, whatever else it is.
We were talking about different multidisciplinary techniques that the article talks about, and one of the things they mentioned, they actually gave us a little shout out, physical therapy. As a physical therapist, we have honestly several things that we do that we can implement to try and help with this. One of the things that I want to stress, though, is that physical therapy techniques that we do in this light isn't necessarily, it's not a cure-all. Kind of like what the article talked about, what you did really well, Christian, alluding to like interventional pain, is discussing that it's not going to work for everybody, unfortunately. I've seen this in my own practice. I'm sure you have too, Christian, where you get very complex pain patients like this, and what you end up doing is you implement things that you think will work, what should work, and sometimes they do a good job at it, and unfortunately other times they don't. For me, the number one thing that I do with everyone is educate. I know you do as well. But the important thing here is that, like the article said, we're trying to set an appropriate treatment expectation, but also trying for the patient. That's my outlook on it, is if a patient is having this debilitating pain, it's taking away from their function, taking away from their, work life, their activities, etc., trying to educate them on what's going on, because I really think that knowledge is power in this case, but also let them know that like things are okay, right? We have some weird stuff going on. It's not perfect. It's, very discomforting, etc. But we ruled out all the bad stuff. We ruled out things like infection, tumor, Sometimes you can get weird referral pain from things like the heart. If you're having a heart attack, why the heck does your low back hurt? It's weird, but that can be the case sometimes. And so we try and rule those things out. And so that's another piece with the education, is just putting the patient at ease, saying, you know what, I know this sucks and it's not ideal, but we know that all the big scary things aren't there right now. So let's move forward then with the next part. So after education, I also try and implement almost on everyone some type of graded activity. And so let's say just something simple like walking, even standing. Let's say standing bothers that neuropathic pain the most. Well, we're going to try and work into some different things like, weight bearing. Let's say it is maybe coming, we think, from more of the low back, working into more of that extension based lumbar spine, different things that we're going to grade over time. It's going to seem like super simple exercise and activities at first, but over time, as the body's able to get used to it and build resiliency, right? Big part of what this podcast is all about, building resiliency. We're able to do a lot of good stuff over time. Now, we might not get you back to running marathons, but maybe you can withstand a day on your feet while you're at work, whatever that might be. And then a couple other things I like to use. It's really interesting. There's some cool literature out there on how, and this might be more on the nosoplastic side of things, but how individuals with chronic pain, especially damage to these neurons like we've been talking about, they have a hard time differentiating between right and left. So lateral discrimination. There's some cool different apps out there that you can get for free on iPhone, Android that I use with my patients from time to time. And it's basically taking them through exercises on discriminating correctly between right and left's part of the body. Next, there's also things such as noxious stim. So what noxious stim is, it's that electrical stimulation. You probably think of it more like TENS. This is just very intense TENS. It's putting the electrodes on different parts of the body, cranking it to a pretty high intensity that might seem a little bit like torture, but I promise you it's not. It's trying to help reduce that pain input, that sensation input from whatever part of the body that is. So we have education, graded activity, lateral discrimination, noxious stim, and then there's some other things you can try. We can try things like manual therapy, right? We can try some things like contrast therapy. So going from hot to cold, doing the extremes. And from what I gather with that research is we're trying to kind of confuse the nervous system, right? What is what? What's going on right now? We're going from one extreme to the next. We're trying to just interrupt this pain pathway to give individuals some type of short-term relief. When reading that article, I tried to think about, all right, what are some more of the bigger things that I like to do with patients? And I know that there's some different needling techniques. It's called perineural, where you put the needle actually very close to something like the sciatic nerve to try and help reduce that type of neuropathic pain. And I think that there's some different cool things out there, but for the most part, I would say that's the handful of things I like to look at doing when it comes to more the physical therapy side of pain management. If you're listening to this, I hope that you're not one of those people that have a really hard time with neuropathic pain and you're trying a lot of stuff and nothing seems to be touching it. Hope that's not you, but individuals who do suffer from that are out there. And a lot of these things we talked about can hopefully help you out.